Welcome to the deep dive. Today we're tackling a topic that I know can cause, well, a lot of worry and, frankly, a fair bit of agony. Renal stones, kidney stones, as most people know them.
That's right. And we've got a really solid set of revision notes here. Our goal is to sort of unpack them, give you a clear, high-yield understanding. Think of it as your guided tour.
Exactly. These notes cover everything, from the basic definition right through to potential complications. So, let's get started. To kick things off, what exactly are renal stones in simple terms?
Well, fundamentally, they're hard clumps, hard mineral deposits that form inside the kidneys. What's interesting, actually, is just how varied they can be.
Varied how?
They can be tiny, like almost microscopic, you'd barely notice,
Hmm.
or they can grow much larger. And they're not all made of the same stuff. Most contain calcium, often with oxalate.
Okay.
But you also see stones made of uric acid and cystine, too.
So these seemingly small things can lead to pretty significant issues then.
Absolutely. Yeah, the main problem is when they block the flow of urine in the urinary tract. That obstruction, that's what causes the intense pain. And if it sticks around, it can lead to, other complications.
Right.
You might hear the term urolithiasis, too. That just describes the whole process of these stones forming. It's worth remembering, about 80% of stones have calcium in them.
80%? That's a really big chunk. And the notes mention different sizes, including something called staghorn calculi. Sounds impressive.
It does sound formidable, and they are. Staghorn calculi are these large stones, often branched, that can fill up the whole collecting system inside the kidney. Really quite something.
Oh.
But then on the other end, you've got stones so small they might just pass without you even knowing. How they form, it's complex. Things like manobacteria, some researchers think they play a role initiating it, and Randall's plaques, these calcium deposits that act like a starting point.
Okay, so it's not just one simple mechanism, mostly in the kidneys, you said, but the notes also mention bladder stones briefly. How do they fit in?
Yeah, bladder stones are less common, maybe about 5% of all urinary tract stones, and they often have different root causes.
Like what?
Things like foreign bodies ending up in the bladder, or obstructions that stop the bladder emptying properly, maybe after an infection. We see them more often in men, particularly those with bladder outflow problems, like an enlarged prostate.
Uh-huh.
But they can happen in women, too, maybe with urinary stasis or, again, foreign bodies.
Okay, got it. So hard mineral deposits, mainly calcium, forming in the kidneys, sometimes the bladder, potentially causing blockage. Now, what actually triggers them? What's the etiology here?
That's the key question, isn't it? And honestly, there isn't one single answer. They're usually a mix of things. Dehydration is a really big one.
Makes sense.
If you're not drinking enough, your urine gets more concentrated, so the minerals are just more likely to crystallize out.
Less water, more stuff dissolved in it. What else?
Diet definitely plays a role. High intake of sodium or oxalate, you find that in things like spinach, rhubarb, and purines, like in red meat and shellfish.
Mm.
These can increase risk in people who are already susceptible.
Mm.
Then you've got metabolic conditions,
Mm.
things like hypercalciuria, that's too much calcium in the urine, or hyperoxaluria, too much oxalate, and gout. These create an internal environment where stones just form more easily.
So what we eat, how our bodies process things, crucial. Any other pieces to the puzzle?
Yeah, certain abnormalities in the urinary tract itself, things that affect urine flow, and there's definitely a genetic link. Family history is important.
Oh.
Plus, other factors like obesity, even certain medications can contribute.
Okay, so it really sounds like a combination, a confluence of factors.
Yeah.
Let's think about who's most at risk then. What are the key risk factors we should keep in mind?
Right, we can break these down. Firstly, anatomical issues, any anomalies in the kidneys or urinary tract that might slow down urine flow. Then, as you said, family history, that's significant. Certain medical conditions, too, like hypertension, gout, and hyperparathyroidism. That's the one affecting calcium levels.
So managing those underlying conditions is key. What about lifestyle? Does that go into it?
Oh, absolutely. Lifestyle matters. Being immobilized for periods can increase risk.
Hmm.
And just, relative dehydration, not drinking quite enough, even if you don't feel super thirsty.
Right.
Metabolically, we mentioned hypercalciuria, hyperuricosuria, that's high uric acid, and citrate deficiency. Citrate actually helps prevent stones, so if you don't have enough.
It's interesting. So citrate deficiency. What else?
Certain exposures, some drugs, heavy metals like lead or cadmium,
Yeah.
and diet, again, of course, high oxalate, urate, sodium, animal protein.
Got it.
Demographics, too. Obesity, maybe surprisingly, higher socioeconomic status seems linked. Age is a factor, typically hitting people between 30 and 60, and historically it was more common in men, though that gap's closing.
So a whole range of things. What if someone's already had one? Are they more likely to get another?
Yes, definitely. A previous stone is a big risk factor for recurrence. The type of stone you had, family history again, and if you got your first stone young, all these increase the chance of getting more.
That's quite a list to remember. Is there like a handy way to recall the main ones?
There is. We can use a mnemonic. How about a family diet could hypercomplicate things?
Okay, break that down for us.
So, anomalies, family history, drugs, immobilization, exposure, type of stone if you've had one before, hyperparathyroidism, age, low fluid intake, metabolic issues, increased salt animal protein in the diet, and yes, meaning previous stones.
A family diet could hypercomplicate things. I like that. That's actually quite useful. Okay, so you know what they are, who gets them, how do they actually form? Let's get into the pathophysiology.
Well, the basic idea is that the urine becomes supersaturated. Too much of certain substances, calcium, oxalate, uric acid, cystine, more than can stay dissolved.
Like too much sugar in tea.
Exactly like that. It starts to crystallize out. These tiny crystals form, and then they act like seeds, attracting more of the same substance, clumping together, and gradually growing into solid stones inside the kidney.
So tiny seeds growing bigger sounds pretty uncomfortable.
It can be, and once formed, they might stay put in the kidney, maybe get bigger there, or they can start to travel down the ureters, the tubes connecting kidneys to the bladder. It's worth noting the specific sort of molecular process can vary a bit depending on what the stone's made of and the person's individual factors.
Right, so different stones, maybe slightly different pathways. Now that classic symptom, the really intense flank pain, how do we tell that apart from other things? Let's talk differentials.
Yeah, this is critical. Renal colic pain can really mimic other acute problems. Biliary colic gallstones, it can feel similar, though maybe more right-sided.
Okay.
A really serious one, especially in older patients with new onset pain like this, is aortic aneurysm dissection. Got to keep that high on the list, particularly over 60s.
Aortic dissection, definitely a red flag one. What else?
Pyelonephritis, a kidney infection, that causes flank pain, but usually with a high fever, and the pain doesn't typically radiate down to the groin in that classic colicky pattern.
Okay.
Then there's acute pancreatitis, acute appendicitis that can cause abdominal pain that might overlap, depending where the stone is.
So location and other symptoms are key clues. Anything else?
Yes. A perforated peptic ulcer can cause severe abdominal pain. In men, you need to think about epididymoorchitis or testicular torsion pain might radiate up, but the key is a tender testicle on examination.
Right.
Also consider sinister causes of back pain, though that's usually tender over the spine itself. And unfortunately, you sometimes have to consider drug misuse people seeking opioids or, very rarely, Munchausen syndrome.
Wow. Okay. So a thorough assessment is definitely needed. Any broader categories we should think about too?
Yeah, absolutely. Other urinary tract stuff like a straightforward UTI, maybe renal cysts, even renal cell carcinoma in some cases. Basically, other causes of abdominal or flank pain need considering.
It's quite a range. You mentioned aortic dissection being key in older patients. Can you give us another quick example question to hammer that home?
Sure. Let's say a 65-year-old patient presents with sudden onset severe flank pain radiating to the groin. What serious differential diagnosis should be high on your list?
And the answer, based on what you said.
Aortic aneurysm dissection. The age, the suddenness, the pain pattern in someone without a known stone history that screams potential dissection.
Definitely one to remember. Okay, let's shift gears. How common are kidney stones? What's the epidemiology look like, especially here in the UK?
They're actually pretty common. Affects about 1 in 10 people in the UK over their lifetime. The incidence of acute renal colic, the painful episode, is around 1 to 2 cases per 1,000 people each year. So your lifetime risk, somewhere between 5 and 10%.
1 in 10 lifetime risk. That's significant. Are there differences between groups, men versus women, ethnicity?
Historically, yeah, much more common in men, maybe 3-to-1 ratio. But that gap's been closing.
Oh.
Ethnicity-wise, highest rates seem to be in white individuals, then Hispanics, then Black individuals, then Asians. Age men tend to peak between 40 and 60, women maybe a bit younger, often late 20s.
Right, okay. And the current picture in the UK overall?
The overall prevalence is estimated somewhere between 10–15%, still a bit more common in men, but like I said, the gap's narrowing. And importantly, the prevalence seems to be going up.
Really? Why is that?
Likely linked to changes in diet and lifestyle factors across the population.
Something we might be seeing even more of then. Got a quick memory tip for those key epi points.
Sure. Just think, roughly 1 in 10 lifetime risk in the UK, gender gap shrinking, and it's on the rise, thank diet and lifestyle.
1 in 10, shrinking gap, rising trend. Got it. Now, what does it actually feel like? What are the classic clinical features someone might present with?
Well, symptoms can vary a lot. Depends on the stone size, where it is, if it's blocking things. But the absolute hallmark is that severe flank or abdominal pain.
The colic.
Exactly. It's often colicky, comes in waves, really intense, and typically radiates, downwards towards the groin or genital area. That loin to groin description is classic.
Right. What else often comes with that pain?
Haematuria, blood in the urine, is very common. Might be visible, might only show up on a dipstick or a microscopy. People often get urinary symptoms too, like frequency, needing to go all the time, urgency, and dysuria, which is pain when passing urine. The urine itself might look cloudy or smell bad, maybe suggesting an infection alongside it.
Sounds dreadful. Any other associated symptoms?
Yeah, nausea and vomiting are pretty common, often just from the sheer severity of the pain.
Yeah.
And if there is an infection or a significant blockage, you might see fever and chills too.
Okay.
But it's important to remember, not all stones cause drama. Lots are asymptomatic, especially small ones that aren't blocking anything. They might just be found by chance on a scan done for something else entirely.
So, not always the agonizing pain then. Okay, example scenario. A patient describes waves of intense pain starting in their back, moving down towards their groin. What's the likely cause?
Based purely on that classic description, renal stone causing renal colic as it moves down the ureter. That's top of the list.
Sounds about right. Okay, so someone comes in with symptoms like these. What are the first steps? How do we investigate?
Right. Initial workup involves some basics. A urine dipstick gives quick clues. Look for red cells, white cells, nitrites suggesting infection. Check the pH. Then you'd send off a midstream urine sample, an MSU, for microscopy, culture, and sensitivities, looking properly for infection.
And blood tests. What are we looking for there?
Bloods help check kidney function. The unis look at electrolytes and definitely check calcium levels. Could hint at an underlying cause. And if you're thinking about any kind of intervention, you'd check clotting PT and INR.
So urine and blood basics first. What about imaging? How crucial is that?
Very. Urgent imaging, ideally within 24 hours, is recommended for suspected cases. For most adults, the go-to is a non-enhanced CT scan of the kidneys, ureters, and bladder, a CT-KUB.
Why CT?
It's just really good at spotting stones. Pretty much all types, sizes, shows you exactly where it is, how big, and critically if it's causing any backup, any obstruction.
Okay, CT for most adults. What if it's someone you want to avoid radiation with, like pregnant women or kids?
Good point. In pregnancy, children, and sometimes younger adults, ultrasound is often the first choice. It avoids radiation. It might miss some smaller stones compared to CT, but it's good at picking up many stones and, importantly, showing if there's hydronephrosis swelling indicating blockage.
Right. And once you've found a stone or someone passes one?
If someone passes a stone, getting hold of it for analysis is so valuable.
Why is that?
Because knowing what it's made of is key to figuring out how to stop more from forming later. So always encourage patients to try and sieve their urine and catch it. And for children and young people with stones, they should always be referred to a specialist for a full assessment, including metabolic workup, because there's a higher chance of an underlying issue.
Got it. So stone analysis and specialist referral for younger patients. Quick memory aid for investigations.
Yeah, how about think urine and blood basics, then bright imaging. Starts with the simple tests, then moves to the scan.
Urine and blood basics, then bright imaging. Nice and simple. Okay, let's talk management. Someone's diagnosed. What happens next?
Well, initial management really depends on how bad things are. Are they in agony? Any signs of infection? Is their kidney function at risk? If the pain's severe and not controlled, if they're septic, or if there's risk of kidney injury, they generally need admission.
And pain relief.
First line, if there are no contraindications like kidney problems or ulcer history, is usually an NSAID, like diclofenac. It works really well for this type of pain. If NSAIDs are out, IV paracetamol is an option.
Okay, pain sorted first. What else initially?
Supportive care. So antiemetics if they're feeling sick, making sure they're hydrated, especially if they haven't been able to drink. Interestingly, antispasmodics don't seem to help much. And as we said, get that urgent imaging done within 24 hours.
Right. Control symptoms, confirm diagnosis. What about longer-term treatment options?
That depends on the stone size, location, and the patient's symptoms. For small stones, say less than 5 millimeters if they're not causing much bother, or even slightly larger ones if the patient agrees, you might just do watchful waiting. let it pass on its own.
Mm-hmm.
For stones between 5 and 10 millimeters, particularly if they're lower down in the ureter, sometimes alpha blocker medication, like tamsulosin, can help relax the ureter and encourage passage. That's called medical expulsive therapy.
So sometimes it's just waiting, maybe with a bit of help. What about managing at home while waiting?
Yeah, lots of fluids, obviously. Simple pain relief like paracetamol, maybe some codeine for breakthrough pain. But, and this is important, if the pain becomes unbearable, or if the stone just isn't moving, or if there are signs of complications, then you need to think about active intervention.
Okay, and what are those interventions, the surgical options?
Several options. There's ESWL, extracorporeal shockwave lithotripsy, uses focused shock waves from outside the body to break the stone into smaller bits that can be passed.
Right.
Then there's PCNL, percutaneous nephrolithotomy. That's more for larger stones, usually in the kidney itself. Make a small cut in the back, go directly into the kidney with a scope, and remove or break up the stone.
Okay, more invasive.
Yeah. And then ureteroscopy. A thin scope goes up through the urethra and bladder into the ureter. You can see the stone, grab it with a basket, or break it up with a laser. Open surgery is very rare nowadays, only for really complex cases. And for bladder stones, often a percutaneous approach works well.
So a whole toolkit depending on the situation. Are there general rules for picking the right one?
Broadly, yeah. For stones under 2 centimeters, especially in the kidney, lithotripsy, ESWL, is often a good first try. But if it's a pregnant woman with a stone that size, ureteroscopy is usually preferred to avoid radiation.
Makes sense.
For bigger stones, complex ones like those staghorn calculi we mentioned, PCNL is often needed. And for small ureter stones under 5 millimeter, expectant management just waiting is often totally reasonable.
Okay, that gives a good framework. Now, prevention. You mentioned stone analysis is key. How do we use that info?
Exactly. Prevention strategies really need tailoring to the stone type. If it's a calcium stone, and maybe they have high calcium in their urine, hypercalciuria, the mainstays are increased fluids, cutting back on animal protein and salt. Sometimes a thiazide diuretic can help reduce urine calcium.
Okay. What about other types?
For oxalate stones, sometimes clostiramine can help reduce absorption, maybe pyridoxine, which is vitamin B6. For uric acid stones, allopurinol is often used to lower uric acid levels. And sometimes making the urine more alkaline with oral bicarbonate can help dissolve or prevent certain stones, especially uric acid ones.
So really targeted prevention. Okay, quick management question. First-line pain relief for renal colic, no contraindications.
NSAID. Specifically, diclofenac is often cited as the go-to, assuming no reason not to use it.
Got it. Okay, so we've treated the acute episode, thought about prevention. What's the long-term outlook, the prognosis?
Well, spontaneous passage really depends on size. Under 4 millimeter, about 95% chance of passing, usually within 40 days or so.
Pretty good odds.
Yeah, but get up to 5-10 millimeters and that drops to maybe 50%. The really key thing, though, is recurrence.
Ah, yes, you mentioned they often come back.
They do. If you've had one stone and don't take preventative steps, the risk is high. Around 50% chance of another one within 5 years, maybe even up to 80% within 10 years.
Wow, 80% at 10 years. That really highlights why prevention matters. Can you just quickly recap main prevention tips?
Absolutely. Number 1, fluids, fluids, fluids. Aim for 2-3 liters a day. Some evidence suggests fresh lemon juice and water helps because of the citrate. Maybe limit fizzy drinks, cut down on salt. Healthy diet, healthy weight. Interestingly, you generally don't need to restrict calcium intake unless specifically told to. And then, as we discussed, potentially medications based on your specific stone type and risk factors.
So lifestyle changes are really powerful here. Okay, finally, let's touch on what can go wrong if stones aren't treated or cause persistent problems. What are the potential complications?
Yeah, several things. Complete blockage, obviously, can damage kidney function over time. If obstruction lasts more than about 4 weeks, the risk of complications jumps up to around 20%.
Right.
Infection is a major worry. An infected obstructed kidney is a surgical emergency, can lead to sepsis, which is life-threatening. Persistent blockage also ups the risk of pyelonephritis, kidney infection, and pyelonephrosis both in the kidney.
Those sound really serious. Any other longer-term risks?
There's some maybe less definitive evidence suggesting links.
Yeah.
Possibly a slightly increased risk of certain kidney cancers, like renal cell carcinoma or upper tract urothelial carcinoma in some groups later in life. And there's ongoing research looking at a potential association between stones and cardiovascular disease, heart disease, stroke. And very rarely, a stone could cause a rupture of part of the kidney's collecting system, leading to a urine leak called a urinoma.
So it's definitely not just about the pain. There can be significant downstream consequences.
Exactly. which is why getting the diagnosis right and managing things promptly is so important. It's all about preventing those complications.
Okay, well, we have covered a huge amount today, really gone deep on renal stones. Just to recap, we've looked at what they are, why they form, who gets them, how they present, how we diagnose them, all the management options from waiting to surgery, the prognosis, and those potential complications.
Phew. It's a
Here.
lot, but hopefully breaking it down helps. Understanding the type of stone and individual risks is just so central to good management and prevention.
Absolutely. And hopefully, for you listening, this has been a really high-yield run-through. Remember, you can always revisit specific sections if you need a refresher.
And it does make you think, doesn't it? With prevalence rising, recurrence so high, what lifestyle changes could really shift the needle on a population level? Something to ponder.
Definitely food for thought. And if you are prepping for the MSRA or just want more top-notch revision resources, do check out passthemsra.com and also fromtiny.com. Really great sites.
Yeah, definitely worth a look.
Thanks so much for joining us for this deep dive.